This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. She is an 80-year-old lady who has this hypermature cataract with pseudoexfoliation and a non-dilating pupil. Now, how to plan surgery in this patient? This case has multiple complexities to deal with. So apart from the pseudoexfoliation and the non-dilating pupil, the zonules would be weak and the capsule looks to be very calcified. I'm not sure how the rhexis is going to be. And lastly, the nucleus also seems to be dense. So with all these complexities in mind, I was debating whether to do phaco or SICS in this patient, but I chose SICS primarily because I wasn't sure about the density of the nucleus and also the anticapsular health. So a peribulbar block is given and I'm sitting temporarily, and let us start the surgery. A conjunctival flap is raised, the episclera is scraped off. The advantage of scraping off the tenons and the episcleral tissue is it minimizes the amount of bleeders which one has to cauterize. I make a small posterior fixation groove on the sclera. A Hoskins forceps is used to stabilize the globe, fixating at the posterior scleral groove which I have created. And then a planned 6.5 mm scleral incision is made with a 50 number blade, and using a crescent blade, a sclerocorneal tunnel is being made. The external groove is about 1.5 mm beyond the limbus, and the inner span of the tunnel would be around 1.5 mm beyond the limbus. Side ports are created. The capsule is stained with trypan blue under air. Let me describe you in detail how to stain the capsule which is under the pupil. The pupil is small, so I want to stain the capsule which is under the pupil as well. So what I do is I just go in, lift the iris with the cannula and inject a couple of drops of the dye under the iris. So this is the way to stain the capsule which is not visible and is under the small pupil. But one important care has to be taken. We cannot inject more dye, because if we inject more dye, there's always a risk of the dye escaping across the zonular barrier into the Berger space. And this is possible especially in eyes with pseudoexfoliation where we have a compromised zonular barrier. So be mindful and watchful of this. If at all you want to stain, use just a couple of drops of the dye under the iris. And when I'm washing out the dye, again it's important to press the posterior lip of the side port incision through which the cannula is placed so that we don't build up any pressure. It has to come out very easily. So if there is a sort of a closed chamber and we are irrigating the fluid, there's always a risk of this fluid going across the zonular barrier into the Berger space and can cause positive pressure during the surgery. This is another small principle which we need to be aware of. OVD is filled into the antechamber. Time to deal with the pupil. In this case, I'm going to do a stretch pupilloplasty. I'm going to use 2 Y hooks through the 2 side ports and then stretch it. I typically would want to stretch it in 4 directions. The stretching is done until we have these small micro sphincter tears. Now the pupil is reasonably well dilated, and we can also see that the capsule which was under the small pupil has also got stained because of our effort of placing a few drops of dye under the pupil. So that technique did work. Now we have a different problem to deal with. We can see a central fibrotic capsular area, and when we want to plan a rhexis, it has to be bigger than this area. So we want to ensure that our rhexis margin is beyond this area of the fibrotic zone. So with a bent 26 number needle, I incise the anterior capsule, try to raise a flap, and then using a micro rhexis forceps through the side port, I begin to tear the capsule to create a rhexis. The capsular opening was slightly irregular and smaller. I need to enlarge this. So I'm going to use my micro scissors to create a small snip there, and then using a forceps, I'm going to enlarge this capsular opening. Now I have a decent sized rhexis. It's almost the size of the pupil, which is about 5.5 to 6 mm. I go in with my hydrodissection cannula and a gentle hydrodissection is done. Now in eyes with pseudoexfoliation, I want the nucleus to be mobile. So that's the reason why I insist on doing hydrodissection, just to confirm that the nucleus is free from its attachment to the bag before attempting to maneuver it. because if the nucleus is still attached to the bag, there is always a risk of us inducing an intracapsular extraction. Now I'm sure that the nucleus is free from its capsular bag. Using the bimanual technique, using 2 Synskukes through the main incision, one Synskuk hooks the equator of the lens, it lifts it up, while the other just wheels the nucleus out of the capsular bag. This is a very effective and efficient technique to maneuver the nucleus out of the capsular bag compared to the single-handed technique. Under the cover of OVD, the nucleus is extracted out using the phaco sandwich technique. So I thought the job is done. I'm just expressing out some of the epinucleus which is there. You can never underestimate what things can go wrong during a surgery. And as the last epinucleus is being flushed out, I am surprised to find that a small tear in the posterior capsule is staring at me. So at this stage, there is definitely an opening in the posterior capsule, but I'm not sure that there is any vitreous. As I move the Y-hook to examine the anterior capsular margin, I realize that there's no vitreous around. So I put in OVD just to prevent any prolapse of the vitreous. I want to attempt now posterior capsular rhexis. So I'm using the Dr. Haldipurkar forceps and a posterior capsular rhexis is performed. Now, since there is not much of a lens matter remaining, at this point I would want to go ahead and place the lens in the bag itself. I have used cohesive OVD to create some space within the bag, and then the proximal haptic followed by the distal haptic is dialed into the bag. At this stage, I see some of the visco and some cortical debris in the anterior vitreous. Although at this stage there is no evidence of any vitreous disturbance, I thought still I would want to go ahead and use the cutter to do some minimal anterior vitrectomy just to clear off all the OVD which is gone behind. So I lift the lens up with the cutter, I go inside and I begin my vitrectomy with the port facing posteriorly, and then you can see that the visual axis becomes very clear. After some time, I then change the direction of the port, make it face anteriorly. Also end up trimming the posterior capsular rhexis margin so that it is reasonably big now. So the visual axis is very much clear. Lens looks to be very well centered. The OVD in front of the lens is just irrigated out. Now before closing, I just like to confirm the absence of any vitreous. Diluted triamcinolone acetate is used and it's irrigated out. There's no evidence of any vitreous. The side ports are hydrated. I notice a small area of Desmond detachment in the superior quadrant, so I'm just using an air bubble. And these are the first day post-op pictures and the patient is doing well. So that was it. Thank you for watching and hope you found this helpful.